All right. Well, good morning or afternoon, depending on where you are. We have but if you're on the East Coast, good afternoon. It's 12 o'clock on a Friday. And so if you know us and you've been with us before, as I say on on these Fridays, NMQF likes to edutain you and give you some information and education around what's happening in the health world of health and healthcare. My name is Brandon Garrett. As you may know, I am the COO, Chief of Staff at the National Minority Equality Forum. And on Fridays, we host these webinars. And these webinars actually were the idea back in 6 years ago now by today's moderator, Dr. Laura Lee Hall. Today, we're going to talk about there's good news around vaccines, the innovative, and I am losing my title. I am losing the title. Well, I'll just say good news around vaccines, and I'll let Dr. Hall give you the rest. Um, NMQF, if you know, is an advocacy education organization, and we've been hosting an annual summit around health and health disparities for the last 25 years now. And so we'll have our annual summit the last Monday and Tuesday of April. So we'll put information about the summit in there in case you're interested. But to move on and just let you know what we're talking about today and do better educating and entertaining, I'm going to turn it over to Dr. Hall, who will lead today's panel.
Thank you, Brandon. Let me share my slides. I guess I'm well known for being an entertainer, huh? Let me get this straightened out here and go into slide mode. I have to tell you, I had a dream over the last weekend that, man, there's so much great stuff about vaccines that's out there, and I'm not letting anybody take that away from me. And I just refuse to accept that. Um, and so we thought that we'd invite like three of the smartest people we know to share with you the good news and confirm why we can be enthusiastic. We will get through this, and we have a lot of good health stuff going to happen to us because of it. Okay, so let me I don't have an introductory slide for my colleagues Chinny and Leslie from, excuse me, NMQF, but they do so much work that's really important to SHC and our community partners and our clinical partners. So let's see. I'm having a hard time with my computer here. All right, I am so blessed to have worked with Dr. Poland for, I think it would be fair to say, almost 2 decades.
Mhm.
Brilliant man, amazingly good man. Um, and I'm showing you some of his credentials here. Um, he's just amazing. Most cited scientist in the field of virology. How about that? And we're very lucky to have him here. And thank you, Greg, so much.
Pleasure.
A newer friend, Tinnis Murray, a family physician. He's at Sanofi, hails from South Africa. And he's really going to share with us some information. It's really a case example of how important and positive vaccines can be. So we're very lucky to have him with us today. Thank you, Tinnis.
Excited to be here. Thank you.
Caroline Poland is a longtime colleague and someone else I'm very blessed to know. And her work, I mean, she was prescient. She was worrying about how to communicate about vaccines um, many years ago. And she's come up with a model and a tool, the empathy tool, that really, as we all kind of try to put meat to the bone on shared clinical decision making in vaccines, her tool, I think, can help all of us move forward in a way and communicate with our patients, our community that is empathetic and effective. So thank you so much, Caroline, for being here.
Thank you.
I'm just showing this, and Leslie, I know will put this the link in the chat box. We have developed a two-pager for both, excuse me, community members and patients, as well as for clinicians on kind of where we see childhood vaccinations. So I know that our pediatricians are getting so many questions. I think these might be very useful, and it has the kind of filter of what's important to people of color. So take it, use it, spread it around. So our talks today: impact and promise of vaccines, real world example of vaccine impact, and effective patient-centered vaccination communications. So I'm hoping that all of you will put your questions and comments in the Q&A box, not the chat box. We'll monitor that. We will get an answer to everyone. Put your questions in there in real time. And if we can't get to every question today, we will get to it and get back to you. The webinar is being recorded and will be available for you to share along with the slides. And we thank all of you who I know work so hard to promote health, public health, and effective vaccination. So thank you so much. And without further ado, I'm going to give it to Dr. Poland.
Thank you, Laura Lee. The delight to be here and to work and talk with all of you and to dialogue. I love the topic here, that there is good news. There's so much negativity, confusion, and chaos that's been introduced into the whole field of vaccinology. But science progresses nonetheless. Science is an iterative process. We get better and better with time. And so I'm going to go over about pretty rapidly, six key pillars that the press really isn't reporting on. And this is good news you need to know. The first is, what new vaccines are coming forward? These, and what I'm going to tell you about, are the vaccines that are in phase 3 trials, or at least late stage phase 2 trials. So this isn't dreams. These are things that are actually happening and moving forward in the development process. As you know, we now have 3 RSV vaccines. These are RSV, respiratory syncytial virus, is an infection that caused so much hospitalization and even death among young children and older adults. We have new routes of vaccine administration that are being explored, such as oral pills or intranasal administration, even transdermal across the skin routes of administration. New pathogens that vaccines are being developed against. For example, particularly in the pregnant women and childhood space, cytomegalovirus, CMV, Group B strep, Epstein-Barr virus, dengue, chikungunya, malaria, West Nile virus, H5N1, hantavirus, Nipah virus. These are things you read about or you hear a little bit about in the press. But what the press doesn't tend to report is this isn't just bad news, there's good news associated with it, because as those are recognized as threats, resources are put into developing countermeasures, vaccines to protect us against the ill effect of those infections. Other ones that you've undoubtedly heard about include Shigella, cholera, staph. You can't go into a hospital nowadays without being worried about Clostridium difficile, or C. diff as it's called. Similarly with E. coli. So that's one area, phase 3 clinical trials that are actually progressing. Another pillar is in cancer vaccines. This is something that should concern all of us, given the prevalence of cancer in the human population. We have HPV vaccines, hepatitis B vaccines. Those are 2 vaccines already licensed and used that protect against cervical and uterine cancer, as well as other cancers, particularly liver cancer when it comes to hepatitis B. There are vaccines being developed against lung cancer, kidney cancer, pancreatic cancer, which is, always a terrible diagnosis because there hasn't been a lot of great progress in protecting people from the effects of cancer. What about non-cancer? Well, that would include Alzheimer's, atherosclerosis, vaccines being developed against hypertension, if you can imagine, opioid addiction, nicotine addiction, and in the field of allergies. So there are vaccines now that will become available against peanut allergy, something pretty common actually in the population, and against poison ivy. So, the whole idea is that these vaccines are not just against infectious disease, as important as those are, and as important as they have been in prolonging human longevity, but in other areas of medicine too. A third platform or pillar is the platforms itself. How do we transmit a vaccine to a person? Well, they're always in the context of a platform. The population knows about mRNA vaccines. They may not know the extent to which they're being developed, including in the cancer space. Vaccine-like particles that can actually be synthesized and then used as a way to not give the whole virus or pathogen, but pieces of it to stimulate immunity. Live attenuated vaccines like dengue, tumor antigens, and multivalent respiratory virus vaccines, and even work on a universal flu vaccine. The idea being that we would get maybe 3 to 5 at the most influenza immunizations in our life and be protected against virtually all strains of influenza going forward. A fourth pillar is in the area of personalized vaccinology, an area that I happen to put a lot of my time and research effort into. And the idea is that we would choose the right vaccine for the right patient at the right time. So we have, for example, 8 or 9, something like that, influenza vaccines that are licensed and on the market in the US. Which is the best vaccine for you? What about RSV vaccines? There are 3 different vaccines. What's the best vaccine for this patient in front of me? What's going to give them the most benefit with the least risk of side effects given their genetics increasingly and the other co-diseases that they may have? Another pillar is in vaccine safety. This one, of course, interests me a great deal. As a vaccinologist, I have suffered a vaccine injury myself. So I'm very interested in vaccine safety, not only for myself, but for the world. I want vaccines to be as safe as possible. And so there's been immense efforts. We've published work looking at cryptogenic side effects, that is, side effects that traditionally may not have been considered or take longer term to develop. Just last night, or maybe it was this morning, the FDA announced a new unified adverse event monitoring system, which they call AIMS, AEMS, which is going to be a real-time, transparent, open to the public database where one can see side effects as they're occurring in the population. This will replace VAERS and the current FDA monitoring system, and so we've heard will be fully implemented by May of this year. And then lastly, because it pertains to some of the other information that will be given to you today, is societal issues. As you know, there's been much made about the bad news in vaccinology, the chaotic public policy, the anti-vaccine bias and stance. Well, I want to look at that in a somewhat positive way, because to the extent that that has happened, I can say that it has caused the field to sort of pause, to sit back, to look at issues like values and ethics, how we educate, equity, how do we engage the population? And all of this sort of basically surrounds the idea of educating people about the scientific method so that they're not going to be dissuaded by things that are frankly nonsense. A good example would be, and you may remember early on, it pretty quickly died out, fortunately, but people thought that if you got the mRNA-based COVID vaccines, that you were somehow magnetized. Well, of course, that was exposed as a complete hoax, but some of the population fell for that because they don't understand the scientific method, and frankly, because we have not educated as well as we should. We have not answered those concerns that the population has. So the refocus on education, the refocus on trust building, I think is huge for us to do in the field of vaccinology. In other words, it's not just the science that we do in the lab, it's the way that we talk about them, educate them, distribute them, and the values that we have to take into account when we devise public health policy that are now taking more and more time and effort, as they should, in the field of vaccinology. So with that, I'm going to end. I'm sure there'll be lots of questions in the Q&A and turn it over to my colleague, Tennis.
Thanks, Greg. What a great introduction to our talk this Friday afternoon. And good afternoon or good morning to anyone wherever you are. On this great Friday, I have been tasked to come share with you some of the good news in terms of new data that's being published every day in vaccines. And this is just one example of many. But today we're going to talk about it's a large body of evidence that was published in about November of last year. And I'll show you towards the end of the presentation the exploratory work that keeps being published on it and that we anticipate will be published out of this work. And it looks at individually randomized studies to assess the benefits of a high dose versus a standard dose influenza vaccine against flu-related hospitalizations in older adults. And I'll set up that conversation just by giving you a quick sort of one-page summary on high-dose influenza vaccine, which was the vaccine under investigation here. It really was the first vaccine to show in over 65 a benefit at preventing infection versus the standard of care at the time, which was a standard dose vaccine. And so it's been used for many seasons. You can see it to the right. In over 12 seasons, we've studied it in over 45 million adults and counting. It was always comparing it against the standard of care at the time, which was a standard dose vaccine. In both clinical and real world settings, we try to maintain randomization as much as we can because we know that that is the gold standard when it comes to generating evidence. And as we continue to generate evidence on it, we started to ask ourselves the question, well, is it possible to show whether this vaccine is not only beneficial in preventing infection and severe disease, but can we show in a study, or is it possible to design a study to show a reduction in particular hospitalizations, such as pneumonia, cardiorespiratory, and even all-cause hospitalizations from getting vaccinated with the high-dose vaccine? That's not a very easy question to answer. These are severe outcomes of disease, but they're often not as frequent. So they're rarer outcomes. It's very difficult to design a randomized control trial in its classical sense to be powered sufficiently to try and answer this research question. So it's something we've been thinking about for a long period of time. And so it required innovation. It required a sort of new way of thinking about how we could potentially design such a study and enter the pragmatic trial design. And it's really a way in which we take the real world setting and try and incorporate it into a trial design. And essentially, what that meant was taking the patient journey. So, however, someone would get their vaccine under normal circumstances and try and duplicate that as much as possible in your trial design so that you can get as many people as possible enrolled into your study. So, essentially, what that meant is whether someone decided to participate in the trial or not, their journey through their health system and through their normal point of care of getting a vaccine is almost identical. And that way, you're able to get more people to potentially participate, but you're also able to save on trial costs so as not to set up dedicated clinical trial sites as you would normally have to do in other settings. So this was one of the innovations to sort of really incorporate this pragmatic approach to trial design to try and do the study. So essentially, this is where we landed, and this has been a long process. We sort of started this planning process in 2021. We landed on Denmark and Spain to go and do the studies in partly because they have national healthcare systems. In other words, the care that's provided is the same in that region or in that country, depending on which trial site you look at here. And they have impeccable electronic health record systems. So that's the other great thing about the pragmatic trial design. We don't need the participants to come back to the trial site all the time. The only contact we really have with them is the day they get their vaccine. And the rest of the time, we monitor the electronic health record system for their outcomes. And that's kind of why we decided to go to these two countries specifically to go and do the trial. I'm not going to go into the details too much, but I'm going to point your attention here to the right. So over 3 seasons in Denmark, 2 seasons in Galicia and Spain, we were able to individually randomize just just short of 500,000 patients in either a high dose or a standard dose vaccine group. And this is something that really has never been done before in influenza vaccine research, to be able to individually randomize such a large group of people. The American College of Cardiology published an independent commentary calling these trials giga trials. And the New England Journal of Medicine, when they did the review of some of these submissions, said that this was a paradigm shift in trial designs and how we study vaccines. So the subject of today's webinar is good news in vaccines. I think one of the first takeaways is here, good news in vaccines is we found new ways to study vaccines, and these are robust ways to do it in large populations, and you'll see the level of data that provides us with to tell the story around vaccines. So what were the endpoints? What is it that we looked at? So as you can see here, both the primary and secondary endpoints, we really wanted to go that one step further. We didn't want to necessarily see, does it prevent infection? Those studies have been done, they've been proven. We wanted to go that one step further and say, well, can vaccination prevent hospitalizations for influenza or pneumonia? Can it, in the secondary analysis or secondary endpoints, hospitalization for cardiorespiratory disease, lab confirmed influenza, and then going even further, all cause hospitalization? Can it impact any hospitalization in these health systems? And then lastly, we also looked at all cause mortality. Now, at face value, extremely boring slide, but don't let that fool you. It is a thing of beauty and it tells the story of randomization. So when you're taught to look at a painting and at a masterpiece, you're often taught to look at it up close, look at the brush strokes, look at the color that someone used, and then you sort of stand back and admire it. And this is very much what you do with a slide that describes the baseline characteristics. So first thing you'll notice here is you'll see the high dose group on the left, the standard dose group on the right. 233,000 patients, more or less, in each group, right? So well balanced overall. And then as you go through each of these baseline characteristics, you can see how well balanced these groups are. And that's the beauty of randomization when you have that in your trial design. You're essentially sitting with two populations or two groups of people who, by their baseline characteristics, are more or less identical. And the only difference between them is that the one group receives a high dose vaccine, the other group received a standard dose vaccine. So you've really created a setting in which you're best positioned to study these two interventions and to compare them to each other. The last thing I'll say on this slide is you can see, and that's the first bullet point here, that close to half the participants had at least one chronic one chronic disease or one chronic condition, which often is the case when you look at population groups and over 65. So also very positive for us because I think you can never talk about influenza in isolation. It's always a bit more complex than that, right? A patient does not just suffer from an infection, but could potentially have one or more chronic diseases. So it was really important for us that we're able to tell a story on the background of how we know patient populations are often set up. So out of those endpoints, just to give you the sort of high-level results, and the results you look at here, because remember we're comparing two vaccine groups to each other. So we don't have an absolute vaccine efficacy. In other words, a group where patients didn't get vaccinated. So essentially, the percentage of the benefit that you see here in the third column is the additional benefit that you get when receiving a high-dose vaccine versus getting a standard dose vaccine. And we're not going to go into these results in too much detail, but essentially you can see for the primary endpoint, hospitalization, pneumonia, or influenza, an 8.8% additional benefit in the high-dose group at preventing those hospitalizations. And then as you go down the secondary ones, two hospitalizations for cardiorespiratory disease, lab-confirmed influenza, even all-cause hospitalization, we saw a reduction in the high-dose group when you compare that to the standard dose group. All-cause mortality was not a statistically significant result in this particular trial. We're talking about good news in vaccines today. The other good news is both the groups, the high dose and the standard dose vaccine groups, over 500,000 or close to 500,000 patients had comparable safety profiles. So these vaccines are safe to give to patients, especially on the background that you have to give flu vaccines on an annual basis at present. To Greg's point, we're working towards that universal flu vaccine target, but for now, people need to come back on an annual basis for a flu vaccine. And it's very encouraging to see that even these large trials, both the high dose and standard dose vaccine participants had no safety concerns that were serious and of note. Now, as is the case, well designed as this trial is, as paradigm shifting as it is in its design, all trials have strengths and limitations, right? Some of these strengths we've already mentioned. It's the largest ever pre-specified pooled analysis of individually randomized older adults. Prospective methodologically harmonized, that just means we had two trial sites, the one in Denmark and in Galflu, and we decided from the start we're going to design the trials in such a way so that it's executed more or less identically in these two geographic sites so that we can combine the results to give us a good pooled analysis. I think it provides critical first of its kind evidence to inform public health and vaccination strategy, and the consistency in findings across the seasons, regions, and age ensures greater reliability and generalizability of these results. Of course, there are some limitations as well. So this was open label. What does that mean? It just means that at the time of vaccination, both the patient and the provider knew what vaccine the patient was getting based on the randomization that was done on the day of vaccination. Of course, as good as these electronic health systems are, there is reliance on routine healthcare data, which may have produced imprecision. We tried to standardize these protocols across these regions, but of course, there's potential for heterogeneity. And then the standard of care with respect to hospitalizations in Denmark and Spain may, of course, differ from that of the United States. So these are just those results, again, just sort of reorganized from most specific to least specific endpoints. And essentially, you would maybe potentially look at that all-cause hospitalization number and say, oh, 2.2% is maybe not that much. Remember, that's all-cause hospitalization, any hospitalization that a health system may experience. And essentially what that means is for every patient that you convert from a standard dose to a high-dose vaccine, you only need to vaccinate 515 to prevent one additional all-cause hospitalization. So in conclusion, this is the largest ever individually randomized influenza vaccine effectiveness study that's been done. And what's wonderful to see is that this provides a framework or a basis to also study other disease areas and vaccines. So similar research is being done for RSV as well as for COVID. And it's wonderful us to see that so that we continue to build the body of robust evidence across the vaccine landscape. And then in this particular case, high dose demonstrated superior protection against these hospitalization outcomes that we mentioned in the primary and secondary endpoints. This is meant to look confusing because, as I mentioned at the top of our presentation, if you're able to individually randomize just under 500,000 patients, you have the potential to study very specific exploratory endpoints, and really the world is your oyster in a sense. And you can see the intention is to kind of really go and study a fair amount of exploratory endpoints out of this same study population, right? So many of these have already, or some of these have already been published. A lot of the cardiovascular outcomes out of this work have already been published towards the end of this year and towards the end of last year and early this year. But you'll see some other really exciting things we want to look into. New onset dementia, there's frailty scores we want to look into. And so COPD, asthma. And so I think the news here is just we'll continue to publish out of this work to ensure that we create a reassurance in the use of these vaccines, their safety, and how they work in some of the most vulnerable population groups that we know could be a potential risk. So that's my story, and I am going to hand over to Caroline to tell us about the wonderful work that she does.
All right, well, it's wonderful to be with you all today and to continue to talk about the good news about vaccines. I'm going to talk about a couple different patient-centric forms of communication that you can utilize, regardless of who you are, and walking alongside someone in their own health and vaccine decision-making journey. And a quick disclaimer from my attorney, this is just general information, not meant to be specific advice to any individual situation. Well, let's start by defining what the problem is. The reality is that people bring their whole selves into decisions about their healthcare, including vaccines. And that includes their past and present experiences, the trauma that they've experienced, the biases, the basic rules of thumb that we utilize as we make decisions, and our physical and mental health. And we can't remove one from the other because we are integrated human beings. And without being aware of this, we can really miss significant contributors to an individual's health decision making. And if we can get above this scene and get this broader view, we can actually understand some of the building blocks that built together inform their decision making. Individuals and the decisions that they make exist within systems and contexts that influence how they think, feel, behave, and act. Of course, we know that coverage rates are plummeting. And the stories that we tell ourselves, including some of the stories we're going to talk about today, and the stories that we hear from others, really significantly shape our decisions in a variety of different areas, including vaccine decision making. And there is good news about patient-centric vaccine conversations. And hopefully by the end of our time together today, you will feel that. I want to start by sharing this quote. We form our beliefs for a variety of subjective, emotional, and psychological reasons in the context of environments created by family, friends, colleagues, culture, and society at large. After forming our beliefs, we then defend, justify, and rationalize them with a host of intellectual reasons, cogent arguments, and rational explanations. And this is the key. Beliefs come first. Explanations for our beliefs follow. So if that's true, what do we do with that? And what's the solution? I'm going to start by talking about cognitive styles. And a cognitive style is simply a basic thinking style. It serves as this lens that impacts all of us and how an individual processes information, takes in, and perceives the world around them, particularly in conditions of uncertainty. And as we're making health decisions and we're trying to navigate through the data and the stories that we hear from people in our communities or our friends or people that we follow online, that is certainly a condition of uncertainty. Now, we all have a preferred primary cognitive style, but we also do have secondary and tertiary styles as well that we utilize to process information. Now, information within the health profession tends to be presented in one primary style, which is the analytical style. Data and facts abound. Now, this reflects the primary style of developers of information and not the population at large. So what that means is that when we primarily use the analytical style where we rely on data and facts, and to be clear, it's not that we shouldn't rely on data and facts, but when we present information primarily through that style, we're actually missing a large percent of the population. We're educating in a way that doesn't make sense to people and doesn't meet their preferred style. So we're communicating up here and they're here and we're missing one another in our communication. So back in 2011, my dad and I published a paper that began to outline this preferred cognitive styles and decision-making model. Now, this model guides healthcare providers, community leaders, science communicators in having very productive conversations that use language and strategies that are most meaningful to the individual with whom we're speaking, instead of communicating in the way that makes sense for us. And that builds trust, that builds healthy communication, and leads to a higher likelihood of behavior change in a variety of areas, including accepting vaccination. In the article that we published, we included a table similar to this that outlines 6 of the most common cognitive styles. And you can see on the left-hand column is the styles that are outlined. The middle column, we've identified examples of what you're looking for in communication to help you identify the style that someone is most often going back to their preferred style. And then in the right-hand column, you can see the healthcare provider, science communicator strategies for actually communicating with someone in that preferred cognitive style. So you can see 3 down is the analytical style, which I've already mentioned. Someone using this style might ask, what are the risks or the benefits of this vaccine? They want to know the data. And so we're going to meet that style with very data-driven educational materials. Now, for these other styles, we don't have to avoid data. It's just how we couch that data that shifts and changes. So you can see the 2 right below the analytical style are fear-based and bandwagoning. These have a lot to do with the stories that people are hearing. And I'm going to talk about stories several times throughout our time together because stories are so important in moving the needle for or against vaccine. And so we don't want to just give data, but we want to meet story with story. And we want to understand the story that they find themselves in, which we'll talk about later on. So if you are interested in learning more about this, you can go back to that article and look in more detail about the strategies that we've outlined. So again, I'm talking about story, and story has a lot to do with communication. And in fact, Stephen Covey has said the biggest communication problem is we do not listen to understand. We listen to reply. And I'm assuming you all have been in a conversation at some point where it feels like the person isn't really listening to you. It seems like they're waiting for a little gap where they can get in their next piece of information, their next piece of data, their next argument. And that is very frustrating. That is not a conversation that I really enjoy having at all. And that's an example of listening to reply. Listening to understand is a stance where we're sitting back, where we are stepping out of our own story, at least momentarily, and we're trying to understand the stories and the fears, the experiences, the motivations, the trauma histories, the cultural impacts of the other person. And when we can do that, we're able to meet that individual where they're at in their decision-making journey instead of expecting them to come and meet us in the way that we want to have that conversation. When we can do that, we can tailor our communication, our compassion, our understanding, our empathy to be in line with the current situation of the individual, not as we've decided their situation to be, but as we've learned that their situation actually is. And the only way that we do that is to get underneath the surface. On the surface, we have the story, and we can all fill out what we think that story is. When we listen to understand, we're getting to the story underneath the story. And that story is where so much power actually is in having these conversations. We can also understand how the past is impacting the present. So often we have the past kind of jumping forward into the present and replaying. And we don't know that until we get to the story underneath the story. When we're listening to reply, when we're looking for those little gaps in space where we can throw out our next data or fact, then we really miss a person's cognitive style. We can't identify those phrases that help us to understand how their preferred communication strategy is. When we're doing that, we miss how they're taking in and processing information and the contributors to what they currently believe about vaccines and big picture how they're making decisions as a whole. So this stance of listening to understand is critical when we're talking about these vaccine conversations. So one way to do this is through something that we've called the Vaccine Decision-Making Empathy Tool. This was something that my dad and I worked on with someone else at Mayo who works in human-centered design. And we worked on defining a tool that you could utilize that would convey understanding, that would support listening to understand, and help us to get to the bigger story underneath the story. So you can see in the very center of this tool is the decision to vaccinate. On one side is for vaccination, the other side is against vaccination. And we're starting by identifying the different people who are impacting their decision, either for or against vaccination, and not just do they exist, but how much of an influence do they have on your decision? And how do you feel about that influence? Because perhaps somebody does have quite a strong influence on someone's decision, but they don't like that that person does. And that's something that we can support them in processing. Then you can see over on the side, and I'll talk about this in just a minute, is boxes that they can go through and check about their values or concerns about vaccination. So like I said, this utilizes principles from human-centered design, and the needs of the person are guiding that process. This is fundamentally a trust-building process between the patient and the person, the healthcare provider or science communicator who's having this conversation. This helps healthcare providers or science communicators to understand a person's values and concerns and influences. And what I love about this is this process meets several of the principles of trauma-informed care, like collaboration and trustworthiness, empowerment, and the acknowledgement of different cultural, historical, and gender issues. So there are a lot of levels to this, though it feels very simple and easy on the surface. And ultimately, this process can help establish felt safety. And when we can make decisions from a feeling of safety, our prefrontal cortex is engaged, and that's where our wise and effortful decision making comes from. Like I mentioned, this is, again, this process of understanding in our listening. So we're going to identify what are the person's values. This is not just individual values, but their family, group, and cultural values as well, and how all of these things mix together. Because values-based decision-making is so important, but sometimes fear hijacks that process, or sometimes the strong influences of someone else hijacks our values. And so this is an important conversation to have. We're also outlining their concerns. So is access a concern or is cost a concern? Just telling someone to accept a vaccine doesn't address some of those concerns that might exist. So again, we're looking at this much more in-depth and broad story that the person is finding themselves in the middle of. And again, you're identifying those influences and how they feel about those influences. We're really trying to tap into the stories and looking for threads as they're sharing their stories. We're getting a very broad view of how people are making decisions, how they feel about the decisions that they're making. And this allows us to have a very empathetic and informed communication with that person and build trust with them. all really great things that we want when we're trying to move that needle towards vaccines. So how do we implement this process? Well, there is a PDF of this tool that is available in the article, but I also have a blank copy. So if you would like a blank copy, I'm going to share my email at the end. Please feel free to email me and I will get that as well as any of the articles that I've mentioned to you today to you. So send me an email if you'd like that. I've heard of some people laminating it and then just using a dry erase marker to actually go through and, you know, walk through that process with someone. You can also print those out and use them as a single use. This can be utilized repeatedly with someone as they slowly move that needle, and as perhaps influences shift and change. And I think that process is really interesting to see how that shifts or concerns or values shift over time. Again, you want to make sure that you're listening for the narratives that that individual is communicating, not the narrative that we have assumed exists, but the narrative that they are actually sharing. And we're really focusing, and I want you to remember this. I know I've said this several times. We're not trying to listen to the story, but we're trying to get to the stories underneath the stories, the much more deep-rooted stories that exist. And remember, this can take time. This is not just necessarily a one-time conversation, but this might need to be done over and over as that needle is slowly moving. Now, I did briefly mention trauma-informed care, so I want to just give a little highlight here. This is a talk in and of itself, but last year, my dad and I, along with someone else, published this paper on trauma-informed immunization practices, and we've outlined a lot of really great information there as well. So here's the name of it, but again, if you want a link to that article, please send me an email. So if all of this is true, then where do we go from here? So a few strategies to take away. Listen to understand those that you interact with. Don't just listen to reply to them, regardless of how busy you are. I know it can feel like you're moving a lot on your plate. You have a lot that you're juggling, but we miss so much about people when that's our strategy. So try to sit back, relax, take a moment and really listen to understand them. And not just understand the story, but their needs, their concerns, their influences, the context and the cultures that they find themselves in, because all of those things impact who we are, what we believe, and how we make our healthcare decisions. This all goes back to reversing our patient education paradigms and communication strategies. It's not about us, it's about them. And so how can we make this process and these communication strategies about the people with whom we're working with instead of building it through the healthcare profession? And finally, hold on to the good news. There is hope moving forward, and we can't let that hope falter no matter what's going on in society at the moment. So again, here's my email address. If you want a blank copy of that empathy tool or any of the articles that I've shared, please feel free to email me and I will get that to you as soon as I can. Thank you.
Thank you so much. Maybe we can have a little positivity, a little applause for our presenters. Thank you so very much. So we got a few questions. I'm going to take the moderator's prerogative and ask a couple. Caroline, are there tools for educating or communicating with the patient based on the way they make decisions in terms of accepting a vaccine, or is that to be developed?
So what we've outlined is primarily in the paper from 2011 that we published on the cognitive styles. So in that paper, we've outlined a series of different strategies. I saw a question or comment about motivational interviewing. So we talk about motivational interviewing, especially with the denialist style. So that paper really outlines a lot of the strategies, different communication strategies for people depending on where they're at in that decision-making spectrum and their preferred cognitive style.
Thank you. And Jenny just put your email in the chat box for those of you who want to follow up, because several people do want to follow up with you. Greg, since you mentioned it before the call, I wonder if you could tell us about VIP.
Yes, that's a good question. So VIP stands for the Vaccine Integrity Project. It's being housed at University of Minnesota. It's been funded, and this is a group of us as national and international experts that will basically provide truly science-based recommendations regarding vaccines. So no politics, no biases, but what do the data show and how should we think about and act on those data? If you will, it's an attempt to replace what the ACIP used to be in terms of unbiased scientific and documented information.
Thank you for sharing that. Now we have a couple questions that I'm going to roll up into one, and maybe Tennis, but all of you will, I think, have important insights. And that's about including people with conditions like cancer or lupus in research regarding vaccines, having clarity around recommendations for these subpopulations, which are big, right? And also, does the research include diversity in terms of race and ethnicity at this point in time? So if you could talk about those two issues.
Yeah, I can maybe sort of start us off. And I think that's what really excites us about this pragmatic trial design is that it tries to mirror what happens in the real world as much as possible. So for this particular trial on the immunosuppression part, there's 24,000 patients who have been included in this, and it's one of the things we'll publish on separately as well. Cancer patients, I think that stacks up to close to 80,000 patients who are in this particular trial with these, sometimes very frequently occurring risk factors. So I think it's a good point, and it's great that we're able to, in trials such as these, start answering those questions too, and we'll continue to publish on it. And I think it's a fair point, should be considered.
Yeah, I'll second that. And this is one of the things, and I mean, I've certainly read the New England Journal papers. I've talked to Tennis about the Dan flu trials. Very impressed with them because they are an actual step forward in answering the question that the questioner asked. Traditionally, what happens is that a vaccine is developed and it's tested on, if you will, the healthy of the healthy, so that it shows a good result. And they've got a starting point with which to get approval and work. But oftentimes, depending on the vaccine, it doesn't include elderly people, for example. And it is difficult. You can't test every condition, every cancer, every autoimmune disorder, et cetera. So you tend to lump, which scientifically might not be the best. Solid tumors are very different than liquid tumors, so to speak, or hematologic tumors. But those studies then tend to follow. The idea behind a pragmatic, and Tennis said something that might have slipped by so fast people didn't catch it, but it's really important. Real world effectiveness. It's one thing on how a vaccine works in a small, highly selected population. It's another thing applied broadly to the population with all the morbidities and comorbidities that the population carries to see how it performs, if you will, in the real world. And I think that's recognized more and more as important. I published an article called Just Vaccine Policy, modeled after the idea of just war. What needs to be included? And a point you touched on, Laura Lee, is you can also see ethnic differences in vaccine safety and immunogenicity. So just policy requires that all of those questions, the questioner said it's more like a 10-part question. And I said, yes, here's somebody who thinks, deeply about vaccines. So congratulations to Jean. I'm sorry, I don't know the last name in that question, because these are really important, and they're important before a population is going to trust the scientists to say, this is a good vaccine, but it has, maybe these side effects, and should be used or not used in specific situations.
Thank you. That's very good. Very good. Um, I noticed in your graph or your drawing, Caroline, that you said pastors were a negative impact on vaccination.
That was just an example.
Better not say that with Dad being a pastor
I
too.
know. Well, I can tell you in our work in community, and Leslie and Shinny and I do quite a bit of it, and we've had some recent publications as well, that people in African American churches, Black and brown churches, their pastor is almost maybe more important than their doctor. And since we work with their pastors, they're very much promoting vaccination and other health screenings, a healthy lifestyle, etc. So I think your
Yeah.
pastor could be moved to the right side of that.
Oh,
Yeah, as
so
well.
yeah, and that's a big disclaimer. This was simply one example. In no
Okay,
way was I suggesting that all friends would be a strong influence for or against, or all family members or anything like that, right? There's pastors all along the spectrum. Your political party could be anywhere on that spectrum, your family, your friends. That's just an example.
It is interesting. And Caroline, I remember when we were writing the paper at the time, and it's
Hmm.
probably why pastors landed where they did, is there was a big issue with so-called Christian nationalism, where pastors more aligned with one political party than another were very negative about the vaccine and were trying to influence people against vaccines. And I suspect that's why we ended up
I
putting
see.
it somewhere.
Yeah, this example was done in 2020, specifically published in a paper on COVID vaccine acceptance rates.
Thank you.
Yeah.
Well, we're coming down to the end of our time. If the three of you would be able to offer 30 to 45-second positive message that everyone here can go and take to their community of influence, we would really love that.
Well, maybe in the order that we talked, I guess, I would say two quick things. On the scientific side, get your information from credible, high quality scientific sources, and don't be swayed by people who are not true experts in the field. On the public side, the work that we as physicians and scientists have to do is to pay much closer attention to the safety concerns that patients bring forward, educating them about the scientific method, and most importantly, I'll leave it somewhat undefined because Caroline will address it, is building, or if I may say, rebuilding trust.
Thank you. Tennis?
I would say keep doing the amazing work that you're doing out there. I think being an advocate for vaccination and being a source of information on vaccines today is more important than ever. And I applaud everyone who keeps doing that.
Thank you. You get to bring it home, Caroline.
Trust is so important. And over the last 6 years, some people have done a fantastic job of building trust, and trust has been harmed in a lot of ways as well. And that needs to be a true north that we hold to. And communication strategies and trauma-informed care play such a role in trust building or harming trust. And it can be overwhelming when we think about shifting communication strategy. So take the mentality of little by little. do one thing, get comfortable with that, add the next thing, get comfortable with that. But you're not going to go.
Oops, we lost her. It is 1 o'clock. It looks like you're frozen too, Greg. I guess it's something happening in Florida. I thank all of you. I thank everyone who's attended. Stay in touch. Let's kind of spread the good news, if you will. Have a great weekend.